And we are live now. We're ready to start.
Good afternoon, everybody. Welcome to our current session on reducing maternal morbidity and mortality related to maternal hypertensive disorders. So we have a number of speakers and a panel that we're really looking forward to, but it is my distinct pleasure to get to introduce our first speaker, who's Dr. Lisa Ollier. And although in our state, Dr. Ollier probably needs no introduction, I'm honored to get to introduce her. She's a professor of obstetrics and gynecology at Baylor College of Medicine in Houston and the chief medical officer at the Texas Children's Health Plan. She received her doctorate in medicine from Tulane University School of Medicine and her master's of public health as well. She completed residency in OBGYN at Baylor University Medical Center and a fellowship in maternal fetal medicine at UT Southwestern Medical School, both in Dallas. And she recently completed roles as the president and interim CEO of ACOG, where her initiatives focused on reducing maternal mortality, including updating ACOG's guidance on pregnancy and heart disease. She's served on numerous committees and in leadership roles for a variety of regional and national organizations, and throughout her career has been dedicated to caring for the underserved and improving women's healthcare by advancing women's healthcare policy. And with that, I'm going to turn it over to Dr. Ollier.
Thank you so much, Dr. Epps. I am so incredibly excited to be here with you all this afternoon and to talk about a topic that means so very much to me. On our next slide, I'll let you know that I have no disclosures. And then let's move on to the learning objectives. This afternoon, I'd really like to go through both national and state data that talk about the impact of hypertensive disorders on maternal morbidity and mortality. Then I'm going to talk about risks of maternal hypertensive disorders on long-term women's health. So it's not just those initial, that initial time period in labor and delivery when a woman has hypertensive disorders, but I'm going to talk about what that means for her for the rest of her life. And then we'll also be talking about opportunities that can reduce the complications from these hypertensive disorders that have demonstrated success. I am really excited to, again, be able to share this with you. I think that this is an incredibly important topic, and it means so much to see so many people who are interested in improving the health care of women and eliminating the disparities that we see in treatment and in outcomes. I want to start with a story that I have unfortunately seen too many times. Some of you may recognize this story. I think many of us have heard her story, Shalon Irving. She was a lieutenant commander in the U.S. Public Health Service Commissioned Corps and a CDC epidemiologist. She earned a dual degree, a dual doctorate in sociology and gerontology, and was an accomplished author and talented chef, a skilled photographer and world traveler, and an ecstatic mother-to-be. All of her education, her affluence couldn't protect her. Just 3 weeks after giving birth to her daughter by cesarean, Ms. Irving suffered complications from high blood pressure and died in February of 2017. She was just 36. Today, her mother, Wanda Irving, is raising her granddaughter. What if she had had timely diagnosis and the right treatment? We could have changed everything. Next slide. Very briefly, I just want to go over definitions of maternal death so that we're all on the same page as we look at a variety of different statistics this afternoon. The CDC and the American College of Obstetricians and Gynecologists define pregnancy-related death as the death of a woman while pregnant or within 1 year of the end of a pregnancy, regardless of the duration or site of pregnancy, from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. Pregnancy-associated mortality, on the other hand, is the death of a woman from any cause while pregnant or within 1 year of the end of the pregnancy. So it's a time factor, whereas pregnancy-related death is truly from causes related to or aggravated by the pregnancy or its management. Next slide. I'm going to start with national statistics. So we have on our left is the pregnancy mortality surveillance system, and this is a very important surveillance system where death certificates are reviewed by epidemiologists and they are categorized. And this data really gives us a very good estimate of the rate of maternal mortality in the United States. On the right side of this slide, you'll see an estimate from the National Center for Health Statistics, and this data was very recently published, the first time the National Center for Health Statistics published maternal mortality data in many years. They felt that there had been enough improvement in the vital statistics data that they felt confident in being able to produce this rate of 17.4 deaths per 100,000 live births. Far too many, ranking us near the top of all developed nations. Let's move on to our next slide. Data from the pregnancy mortality surveillance system give us a picture of the relative contributions of different diseases to the overall maternal mortality rate. And you can see hypertensive disorders of pregnancy there in red, accounting for about 4.7% of the deaths captured in the PMSS system. Cardiovascular disease is the leading cause at about 15.5%, but again, hypertensive disorders are extremely important. Included in this category are gestational hypertension, preeclampsia with or without chronic hypertension, and eclampsia. And these conditions affect nearly 5 to 8% of the 4 million pregnancies in the United States each year. In the United States, the rate of preeclampsia has increased by about 25% between 1987 and 2004, so a common problem and an important cause of maternal mortality. Next slide. I think in any work that we do, any talks that we give about maternal mortality, all of us talk about the significant disparities in pregnancy-related mortality. Rates for African American women are significantly higher than for women of other races. While the difference in the rate varies from state to state, overall the rates are 3 to 4 times higher for African American women. In detailed analyses, rates are also significantly higher for American Indian and Alaska Native women. We will not achieve significant reductions in maternal mortality and morbidity without addressing the gaps in care for Black women and for American Indian and Alaska Native women. Next slide. While essential, our vital statistics data tell us only a small piece of the overall puzzle. State-based reviews provide us with the best opportunity to comprehensively assess and characterize maternal deaths and to understand the causes and contributing factors and identify opportunities for prevention. These review committees, with access to medical records, autopsies, investigative reports, and other information, supply a much stronger understanding of the causes and contributing factors to maternal death. Let's move on to our next slide, where we look at information from the Texas Maternal Mortality and Morbidity Review Committee. Next slide. Obstetric, hemorrhage, preeclampsia or eclampsia, infection, and embolism were all tied for the second leading causes of pregnancy-related death in our 2013 cohort. These underlying causes of death, with the addition of cardiovascular and coronary conditions and mental disorders, account for 74% of the 54 pregnancy-related deaths that were reviewed by the time of the publication of our biennial report in the 2013 case cohort. Cardiomyopathy and pulmonary conditions tied for third, collectively accounting for 12% of the pregnancy-related deaths. These findings here from Texas are comparable to what you saw in our national data and are comparable to data reported to the Centers for Disease Control and Prevention by other maternal mortality review committees. Next slide. In Texas as well, we also see the significant disparity in maternal mortality. Among reviewed 2013 pregnancy-related death cases, 31% of the deaths were among non-Hispanic Black women, while they represented only 11% of the live births in the cohort. 26% of the maternal deaths occurred among Hispanic women, while they represented 48% of the live births in the cohort. The Department of State Health Services will determine the final size and the racial ethnic distribution of the 2013 pregnancy-related deaths after the review committee completes the review of the 2013 case cohort. Next slide. We see significant disparities in hypertension here in Texas. The overall rate of delivery hospitalizations involving hypertensive disorder diagnoses increased significantly from the period 2011 through 2018. Non-Hispanic Black women had the highest rate of delivery hospitalizations involving hypertensive disorder. And you can see that clearly illustrated on our graph here with non-Hispanic Black women at the top of the graph. Next slide. We also see high rates of delivery hospitalization with hypertensive disorder throughout the state, but more concentrated in Central and Southeast Texas counties. Rates of delivery hospitalizations involving hypertensive disorder were highest among non-Hispanic Black women, and they varied across the counties that you see here. I'll pause for a moment to let folks take a good look at the map and identify their own counties. On our next slide, we look at preventability. A death is considered preventable if the review committee finds that there was at least some chance of the death being averted by one or more reasonable changes to the circumstances of the patient, provider, facility, systems, or community factors that we believe contributed to the death. The review committee determines if there was no chance, some chance, or a good chance of that death being averted. The review committee determined that there was at least some chance for preventability in 89% of the pregnancy-related deaths that were reviewed in the 2013 cohort. And as you can see here, all of the reviewed pregnancy-related deaths due to hypertensive disorders were believed to be preventable. Next slide. The good news is we really are making progress. Next slide. I'll discuss briefly several solutions to address hypertensive-related mortality: the TexasAIM program, maternal early warning systems. I'll talk a little bit about telemonitoring programs, and then postpartum clinics. Next slide. The TexasAIM program is an important intervention that has been put into place to significantly reduce maternal complications, reduce severe maternal morbidity, and end preventable maternal death. Hospitals and communities work with state teams and health systems to improve maternal safety by implementing safety bundles. These AIM safety bundles consist of instructions, checklists, and supplies for healthcare staff to effectively prepare for, identify, and prevent severe complications that arise from specific causes. Each bundle is developed by official representatives from medical organizations and public health departments, as well as patient advocates. Each is vetted by the National Council on Patient Safety and Women's Healthcare and is reviewed semi-annually for updates. These bundles represent evidence-based best practices for maternity care and are endorsed by many national medical organizations, including the American College of Obstetricians and Gynecologists. The Department of State Health Services here in Texas has partnered with the Texas Hospital Association to implement these maternal safety bundles here in Texas. There are safety bundles that we are implementing first for hemorrhage, but now moving into the safety bundles for hypertensive disease and for women who have substance use disorders. On our next slide, we can see provisional findings from the implementation of the hemorrhage bundle that does show a reduction in the rate of severe maternal morbidity among hemorrhage cases that occurred during the initial intervention period. And I'm very hopeful that we will see the same positive results with implementation of the severe hypertension bundle. We have seen positive results after implementation in other states, including the state of Illinois, where they saw a significant improvement in the time to treatment. Treatment within 60 minutes improved from 41% to 85%, and that improvement was sustained over time. They saw a concurrent decrease in severe maternal morbidity and in mortality from 15% at baseline to 9%, with an overall reduction of 41%. Next slide. I love this because one of my dear friends is featured here, Dr. Davidson. Maternal early warning systems seek to implement protocols into practice that facilitate the timely recognition, diagnosis, and treatment for pregnant women who are developing critical illness. And by having that timely diagnosis and treatment, preventing or avoiding maternal morbidity and mortality. There are several essential components, including criteria that prompt reporting to a clinician, effective notification and escalation protocols that prompt bedside evaluation, and then appropriate treatment protocols to ensure that each woman receives the care that she needs. These maternal early warning systems are being implemented in Texas, and the TCHMB provides Muse technical assistance to all TexasAIM hospitals. Next slide. Here's an example of maternal early warning systems that have been used in the literature. There are several different processes that exist for these types of systems. Examples include trigger systems versus point systems. The idea really is to get the provider to the bedside faster, to get the intervention to the patient that is appropriate. On your next slide, we can see results that were published after implementation in California hospitals. And I've highlighted in the box the reductions in composite morbidity and the reductions in eclampsia in the implementation groups that you can see on the left side of the slide compared to non-intervention groups on the other side. So improvement, reductions in complications with the maternal early warning system implementation. Next slide. Postpartum follow-up. Postpartum follow-up is incredibly important, and for a long time, we really thought of it as you need your postpartum appointment, follow-up in 6 weeks in a clinic. And it's really so much more than that. It's so incredibly important for us to really be thinking of postpartum care as an ongoing process rather than as a single appointment. And we need to think about it so that we ensure that the services and support are tailored to a woman's individual needs. Because of the substantial risk of complications from women who have hypertension at the time of delivery, it is very important for these women to have early follow-up. More than half of pregnancy-related maternal deaths occur early. Blood pressure evaluation is recommended for women with hypertensive disorders of pregnancy no later than 7 to 10 days postpartum. And women who have severe hypertension should probably be seen earlier than that, within about 72 hours. it's critical that these assessments occur because more than 1/2 of postpartum strokes occur within 10 days of discharge. Next slide. Just briefly, there are a number of telemonitoring programs that have been published in the literature, and there are an increasing number of programs that have been implemented. So I want you to be sure and take a look at these types of programs that can really help us do a better job of detecting and intervening for women who have persistent hypertension following delivery. Here I have just 2 graphs showing the disparity in the improvement in blood pressure following preeclampsia at the time of delivery for Black women and for a sample of white women. You can see that for African American women, their blood pressures were higher over the entire time course of this monitoring. Next slide. So I want to change gears just a little bit here and talk about, in our remaining time, about the long-term effect of preeclampsia on cardiovascular disease. It's important to understand that cardiovascular disease is the leading cause of death in the United States. It's the leading cause of death for women. And in fact, the population-adjusted risk of cardiovascular mortality is greater for women than men, 20.9 versus 14.9. The evidence that preeclampsia is, in fact, an important risk factor for future cardiovascular events is becoming stronger and stronger, and it's very clear that hypertensive disease really needs to be included in risk assessment systems for the development of long-term cardiovascular disease. Next slide. So I know that this is a busy slide with a lot of information, but I think it's a really great way for us to look at a lot of the research that has been published on this topic and look at it in a very structured way so we can make an assessment of the impact of these studies overall. So we've got cohort studies that follow women prospectively, and then we've got case control studies that can sometimes look retrospectively. And what we see here is pretty consistent finding that, in fact, preeclampsia is associated with the subsequent development of cardiovascular disease. In fact, there's an odds ratio of over 2 for that association. This is really important information for us to have as women. It's important for our obstetric care providers, but it's also important for any provider who takes care of us during the remainder of our life. These risks are important, and I'd like to talk about some ways that we can change our follow-up and mitigate the long-term risk. Next slide. Okay, so here we have a wonderful illustration looking at the associations that we see between being overweight or obese, diabetes, and hypertension, and then the complications, the hypertensive disorders of pregnancy here in the middle. And then you can see in less than 10 years, we've got plus signs that denote the risk for these complications. So women who have gestational hypertension and preeclampsia are both at risk for cardiovascular disease and for subsequent hypertension. And you can see that when you add those conditions and a small baby or add a preterm delivery, the risk is even greater. When we look at more than 10 years out, you can see once again significant risk for women with preeclampsia of cardiovascular disease, hypertensive disorders, coronary artery disease, etc., and a greater risk of mortality. So these findings are really important for us. On our next slide, we have specialized clinics that provide a structured evaluation and intervention program for women who have hypertensive disorders of pregnancy. One of the examples is the Maternal Health Clinic at Kingston General Hospital in Ontario. It was started by a colleague of mine who does just a wonderful job helping these women understand their risks, have them undergo expanded screening and assessment, and then have targeted interventions to help them, again, reduce their risk for the remainder of their life. Next slide. We can look at pregnancy as an opportunity for us to identify women who have these cardiovascular risk factors. And we can take someone who is in this top box, this red box of risk, and with interventions, reduce her ultimate long-term risk of cardiovascular disease. So what might some of those risk reduction strategies be? Well, we'll see those on our next slide. Things like breastfeeding can actually help reduce risk. Maintenance of a normal weight, not smoking, increased physical activity, and a healthy diet. All of these things can really help a woman reduce her risk and really help prevent diabetes, metabolic syndrome, and then subsequent progression to cardiovascular disease. So important new information that I think you need to have, and it's an opportunity for us to have another chance to intervene. We'll move to my final slide. I just want to say thank you. I ended up talking a little bit longer than I had planned, but I am happy to take any questions if you do have any. Dr. Epps.
Dr. Lee, there was one question, and then I actually have a couple depending on our timing. So there was an attendee who asked, in regards to what you were discussing with postpartum follow-ups, how do you feel about postpartum follow-ups being via telemedicine, especially in the time of COVID? And for context, this was a person who had a C-section, a preeclampsia diagnosis, and all of her follow-up visits were via telemedicine. So wondering your thoughts on that and kind of weighing the risks and benefits.
Yeah, that would have to be a very much an individualized discussion for me to understand what technology she has at home. You know, am I really going to have a system that is accurately transmitting her blood pressure data? Does she also have a scale at home? Am I able to follow that? How often am I able to see her? Are her blood pressures improving? Is she on medication? So there's a lot of things. Do I think some of the follow-up can be through telemedicine? Absolutely. Absolutely, I do. Can all of it be through telemedicine? Maybe. I think it just depends. I would say that's very situational.
Another question, but first acknowledgement. So it's from Kimberly Pilkington, who says, thank you as always for your passion to help us care for women and their families. Do you know of any recent data showing a greater occurrence in postpartum development of preeclampsia? Is it just that we're monitoring for it, or is there, and therefore a diagnosis, or do you think it's actually a rising problem? And I was just going to add to that anecdotally, I feel like as my hospital has started doing, sending people home with blood pressure cuffs, our readmissions for preeclampsia have gone up. So I think that's a very interesting question.
I think it is an interesting question, and it is hard to differentiate that, right? Because I think part of it, I do think it is. I think we are seeing higher numbers. Is it because of the stressful situations in which everyone is finding themselves? Is it our better diagnosis? Is it a combination of a number of different factors that's difficult for us to measure? Probably most likely the latter, but I do think it's important. It is important for us to be able to do that postpartum blood pressure monitoring a little bit more closely than perhaps we might have in the past.
Thank you. There is another question, but I'm actually going to hold it because I think the next group is going to do a really good job of answering that. So I'm going to hold that other question. Thank you so much, Dr. Ollier. Now it's my great pleasure to introduce Dr. Ortiq, Dr. Carla Ortiq, who's going to moderate the next session. She's a clinical assistant professor at Baylor College of Medicine within obstetrics and gynecology. She's a compassionate physician who's dedicated her medical practice to women's healthcare issues and the elimination of racial and ethnic healthcare disparities. She's board certified in family medicine and obstetrics and gynecology, and she's a fellow for ACOG. She's a clinical assistant professor in the Baylor College of Medicine. That's my own college. You think I could say it correctly? And a partner of the Women's Specialist of Houston at the Texas Children's Pavilion for Women. Dr. Ortiz has served as a member of the Texas Collaborative for Healthy Moms and Babies, executive and chair for the Texas MMMRC. She was chair of the Texas State Subcommittee on Maternal Health Disparities and serves as the co-chair of the Houston Improving Maternal Health Steering Committee. Dr. Ortiz.
Thank you, Dr. Epps. And thank you to all of the panelists, to Dr. Ollier, for that informative presentation. I'm really honored to moderate this afternoon's session on quality improvement approaches to positively impact outcomes related to maternal peripartum hypertensive disorders, with a focus on eliminating racial and ethnic disparities in these outcomes. As was just highlighted by Dr. Ollier, maternal hypertensive disorders, preeclampsia and eclampsia, are among the leading underlying causes of pregnancy-related deaths in Texas and the US. In Texas, the overall rate of delivery hospitalizations involving hypertensive disorders increased from 2011 through 2018. This rate varied by county and was highest in non-Hispanic Black women. Of note, as Dr. Ollier mentioned, in the most recently completed pregnancy-related death cohort, 100% of the deaths where hypertension was a contributor or was the underlying cause were identified as having some chance of being prevented. This brief overview highlights the importance of this topic and emphasizes that there is space for improvement. We have a distinguished panel assembled of experts in their fields, and they are going to provide us with some insights on actionable initiatives. Our first panelist is Dr. Sarosh Rana. Dr. Rana is a professor of obstetrics and gynecology and section chief of maternal fetal medicine at the University of Chicago. Her clinical interests include diagnosis and management of hypertensive disorders of pregnancy. She takes care of pregnant and postpartum patients with high-risk conditions such as preeclampsia, hypertension, kidney transplant, heart failure, and obesity. She also performs translational research. For the past 15 years, her lab has worked on finding new biomarkers and treatment of preeclampsia. She's particularly interested in elucidating the role of angiogenic biomarkers in the prediction of adverse maternal and fetal outcomes. She conducts national and international studies. She trains medical students, residents, and fellows, and I'm honored to have served on a panel with her in the past. She is going to provide an overview of the impact of peripartum hypertensive disorders on health outcomes and the systemic treatment and management of postpartum hypertension QI initiative at her institution in Chicago. Dr. Rana?
Thank you very much. I'm going to share my screen quickly. You have to tell me if it's, yeah. Can everybody see this?
Yes.
Yes. Okay, great. So thank you very much, for Dr. Ortiz for a great introduction. I will dive right in, and in terms of the question answers, we can perhaps go through it, or I can't keep a chat box while I'm talking, so maybe somebody can keep a tab on the questions. So I am going to talk maybe for 10 minutes to 15 minutes about this initiative that we did at the University of Chicago. And like Dr. Ortiz was saying, and the previous speakers as well, so hypertension is a major problem And it's actually a disease that is, I feel like it's really contributing to disparity in terms of maternal health, such as women who are African American, Black, are at higher rates to develop preeclampsia and related hypertensive disorders, but they're also at higher risk to have complications related to high blood pressures in pregnancy, and also suffer more in terms of even mortality. So this is just the CDC and statistic that was published a couple of years ago, that the absolute risk of death during pregnancy is as much as it is happening during pregnancy. So it's about 31%, but there is a significant proportion of maternal mortality that is happening postpartum. So about 36% of the women are dying within delivery to 1 week, and a significant proportion, about a third, are actually late postpartum deaths, such as occurring within 1 week to 1 year. And I'm just as an introduction, I don't have that slide, but preeclampsia is a major contributor to maternal morbidity and mortality. And like previously pointed out, there are lots of good studies and hospital-wide data showing that there are certainly areas of improvement when a lot of these majority of these morbidity and mortality are occurring, when perhaps some intervention could have been done, and perhaps the outcome would have changed. So some of the things that we recognize at the University of Chicago in terms of a hospital-wide approach to management of hypertension. So the previous speaker, Dr. Hollier, I think pointed out about the ILPQC. So ILPQC is the Illinois Perinatal Quality Collaborative, and they did come out with management of acute severe hypertension for blood pressures more than 160 or 110. And the goals was management. For example, you have to treat the patient with IV antihypertensives within an hour. And I think most of the hospitals, and I was the physician lead at the University of Chicago, we did very aggressively have a plan for management of antepartum and intrapartum severe hypertension. But one of the things that one of the components of that ILPQC protocol was also management of postpartum hypertension. And at the same time, ACOG came out and said, we have 4 trimesters of pregnancy, so we need to pay attention to the 4th trimester in terms of, discharging these patients and adequate follow-up. But at least at the level of our hospital, what I found was that at the time of admission and discharge, there was a general lack of knowledge among patients about the long-term effects. So Dr. Hollier was pointing out, these women are not just at risk for really long-term effects. So this was, 10 years ago, 20 years ago, people are saying, oh, you are when you're 45 years old, when you're 50 years old. But there's lots of recent data that women who are postpartum have a much higher risk to develop immediate postpartum hypertension within 1 year of their delivery, within 2 years of their delivery. So we kind of have this, gap of knowledge even among patients. If you ask them, what is your long-term effects of preeclampsia, for example, on their immediate health and also their long-term health. At least in our institution, we did not have an organized effort to educate our patients. So we would have over and over again all these women who come in with a diagnosis of preeclampsia, but there was no organized effort. So there was nothing that you could say, okay, these are the 3 things that we're going to teach each patient who has preeclampsia. We also discovered that we were not giving these discharge instructions universally. So although ACOG was saying you have to discharge them, somehow create a path so that these women can follow up in 7 to 10 days as dictated by ACOG, but we did not have, at least in our hospital, we did not have uniform discharge instructions. And then we wanted these patients to come back in 7 to 10 days for a blood pressure appointment, but there were really no dedicated postpartum clinics. So access to care was very difficult for these patients to come back. And early on, we didn't even know how to bill for these visits because they're not really the postpartum visits. They are, 10 days out from your discharge. Then we also found that there were lots of kind of problems that we found in the ED, such as these patients, when they were coming back, for example, they would come back through the emergency department. And in the emergency department, we did not have a systematic way to identify these patients. So the postpartum women would be in the similar line as somebody else who's sitting there with a non-acute problem. So they would sometimes wait for hours and hours before being seen. There was actually quite poor knowledge among the providers who were there in the ED about postpartum hypertension. So a lot of people are still kind of thinking, oh, preeclampsia cures, delivery cures preeclampsia, and they were kind of unaware of the significance of having blood pressures after delivery. And many a times they would either call medicine or cardiology instead of OB because they thought that, oh, the patient is already delivered and now she needs to be either be seen by medicine and cardiology. And even in the ICUs there in the in the neuro ICUs, we would see patients who get admitted with severe headache and would not get, for example, with hypertension, they would not get treatment for hypertension, nor will they get magnesium. There was always a delayed transfer to labor and delivery. And like I said, there was really delayed recognition and treatment of severe postpartum hypertension. So although we had protocols of management of postpartum hypertension in labor and delivery, and it was quite robust because of the ILPQC, there was actually no systematic protocol in the ED for management of postpartum hypertension. And then even if the patient like goes through all those hurdles, we had no standardized management for readmission. So even if she got readmitted, different physicians, for example, would treat the patients differently, whether to mag them, not to mag them, whether to remag them, whether to get the labs, whether to admit patients. There was like a not at all a systematic approach to anybody who was coming back to the hospital with hypertension. So what we did was we created a team and we called it STAMPP-Hypertension. So it's systematic treatment of management of postpartum hypertension. And I felt like because of ILPQC we were quite good with antepartum and intrapartum hypertension, but so I really focus a lot of attention to management of postpartum hypertension. And essentially we just, had a team of people mostly driven by nurses. And then I had few fellows and residents, and we got some funding from our women's board just to buy the blood pressure monitors. So we created some goals, and one of the goals was, my big goal was to improve the knowledge among providers and patients. So I really wanted to kind of, this was about 4 years ago now, we really implemented this in 2018, but I really wanted to hone in and teach the providers and the patients the relevance of the post delivery period. We obviously wanted to have a timely and appropriate management of hypertension in the postpartum period. The big goal was to reduce the hypertension related complications, but also one of the big goals that we had was to really improve the rates of postpartum follow-up. So there is lots of data that Black women actually have very poor rates of postpartum follow-up. In fact, in our baseline data, I'll show you the rates of follow-up was 30%. So 30% of the people came back for any of these appointments that we made for them for postpartum blood pressure check. We also wanted to improve the management of readmissions because that was very chaotic. And then, like Dr. Hollier was saying, we did go ahead and actually wanted to improve their long-term postpartum health. So I collaborated with one of the cardiologists here who is very interested. She's a young physician. She's very interested in long-term cardiovascular disease among women. So we send a lot of our patients to her in terms of doing their postpartum long-term cardiac health. And then obviously any program, I can run it for a little while, but for sustainability, I can say that we had a lot of nursing involvements. On the pictures on the right, you can see that that's just one of the, I was doing a lunch and learn. This was pre-COVID. So we would have all our nurses, and we were very proud of our blood pressure monitors that we were giving to all the patients. That's a cake. I think this is May 5th when we celebrated the World Preeclampsia Day. So that I would just like sit there. It's an open mic. Anybody can come and ask me any questions. So it was very, very fruitful. Then we also did a lot of education to the care providers, such as I developed an annual competency, and now ILPQC actually requires it, and JCO requires it, that every delivering hospital has a hypertension competency. So we already created that. And it's a long video. Everybody has to watch and answer questions before and after. And then I did some media stuff. We celebrated the World Preeclampsia Day. We had like lots of electronic bulletin all across the hospital, like talking about the relevance of preeclampsia all day long. I did a Facebook Live. We did some webinars. Obviously, this is a great platform for people who are listening. And then I started collecting data to actually show that there was quality improvement just for future funding, and take it to the next step. So what's the program? It's actually pretty basic in terms of, so what we did was one of the, so it has different components, and one big component for education, we created this YouTube video. It's actually free to download. It's a little bit proprietary in a sense that, I mean, it's no copywriting, but it has a lot of mention of University of Chicago towards the end, but it's just a video of me and a couple of nurses talking about what is preeclampsia. So what we did was every patient who comes to the unit to labor and delivery and gets admitted. Now we're showing it to every patient, but we started out by showing it to patients who have some sort of a hypertensive disorder. They cannot switch on their TV till they watch this video. It's about 5 minutes long. And they watch it, and it talks about importance of postpartum hypertension and the kind of the program we have at the University of Chicago. Then we started giving these written instructions. So thank you to Preeclampsia Foundation. These tools are actually available free of cost. So we ordered it from them, and we actually took this snapshot of this, you are still at risk after delivery, and put it in our dot phrase. So we have EPIC. So we have an EPIC dot phrase which comes up for postpartum hypertension discharge. So we have a standardized discharge instructions that's given to all patients. We also bought these bracelets which says postpartum on one side and preeclampsia on the other side, and we give it to our patients and we tell them to wear it in case they show to any emergency room or somewhere they can actually tell somebody that, it's like a medical bracelet. And we give them blood pressure cuffs and monitors. So I've actually hired a nurse who exclusively only does preeclampsia education every day to all patients who have any kind of hypertensive disorder. So she gives out these blood pressure cuffs. We teach our patients how to monitor the blood pressure, and then we give them a little a sheet where they can write their blood pressures and warning signs of preeclampsia. We also, on the medical side, standardize all protocols. So I went through all the protocols that we have this institution about management of postpartum hypertension. We created postpartum hypertension clinics. So actually, telehealth has been a little bit of a blessing because we seriously converted pretty much all our clinics unless the patient has to come in into a postpartum telehealth clinic. And then we also worked on standardization of protocols for the readmissions, and a significant amount of work went into creating the ED workflows as well. So this is an example of the postpartum preeclampsia care sheet that we are giving to patients. It's very simple. It just talks about know your signs of preeclampsia. It then says, know your risks. So your risk for seizure, stroke, organ damage, death. We made this green, orange, and red. So the green is your blood pressure should be less than 140/90, and red is a hypertensive crisis. We wrote down the numbers for our clinic where they can call during the daytime. And then we, kind of have some instructions of how to take the blood pressures, and then simply date and time and what your blood pressure was. And you'll be surprised how many patients are actually, with all this education, filling this out. And I see over and over again, my patients, they have these sheets like filled out with their blood pressures. We also kind of did a significant amount of streamlining of education in our outpatient clinic. So what I've done now is that every patient who gets triaged through our MAs in the first trimester, they get this pamphlet, which is ask your physician about, and again from Preeclampsia Foundation, ask your physician about aspirin. So I'm not telling the MAs obviously to counsel the patients about aspirin. I'm just giving this, everybody gets it. So by the time they get to my clinic and they're sitting with me, they'll say, oh, somebody gave me this, Dr. Anna, do you think I would be a candidate for aspirin? And I feel like it's very, very good resource. It's very pictorial, so the patients can easily understand it. Then in our clinics, we give this preeclampsia sheet after 20 weeks at least twice. So once I give it to them around 20 weeks, and once I give it to them a little bit later in the third trimester, and I tell them to put it on the fridge or somewhere where they can have easy access to it in terms of looking at it every day, so that they can review their signs and symptoms of preeclampsia. And then when the patients come back for their 6-week appointment, we give them this this pamphlet which says preeclampsia at risk of heart disease, and we make their appointments with the cardiologist. So I'm not gonna, I think I'm probably running late on time. So these are some of the protocols, and I'm going to publish this paper. It's already in press. So this is all going to be hopefully open access, so you can obviously adapt it. But this really is very simple. Again, just a lot of effort went into it to make it not overtly complicated. It's very simple. You have severe hypertension treated this way. You have mild degrees of hypertension, you treat it this way. And I developed this mostly from consensus opinions, mostly from my MFM colleagues. These are just again, everybody has access to it, and you can modify it based on the resources that you have. But again, simple kind of workflows for how to manage patients when they come back for readmissions. I'm going to quickly go through. So this was kind of one of the, I feel like, easier channels. What we did in our ED is that simply one thing we did was we changed the way that the patients were coming back. So I had to work with the labor and delivery leadership, but essentially all our patients are now coming back to labor and delivery if they have any hypertensive issue up until 6 weeks. But if a random patient shows up in the ED, we've made it very clear to them. We said, you have to ask only 2 questions. Are you postpartum? And if you have hypertension, if any of those things are present, unless you're obtunded, so unless you are in respiratory failure, actively seizing, or heart failure, or you have altered mental status, you just ship the patient to labor and delivery. And we found that it's so much easier for these patients just to come to labor and delivery quickly and get their treatment, rather than trying to create a whole channel of resources that were required in the ED. So quickly going over what we found. So we collected data on about 1,000 patients, so 926 patients. And our patient population, as you can see here, is a large proportion is Medicaid. So we have 65. So these are women who have hypertension in pregnancy. So about 65% of them were Medicaid. Significant proportion, about 80%, are actually African American Black, so the right kind of patient population where you want to make a difference. And then majority of the patients in this cohort had a diagnosis of preeclampsia and gestational hypertension. And long story short, what we show that just by education and creating these spaces for these patients to come back, we were able to improve the rates of postpartum follow-up by 23%. So, again, in terms of improving outcomes, I think this is a very good thing. And the other thing we showed was it actually benefited both types of patients. So our African-American Black started out with 30%, they went up to 55%, and our Caucasian women went up from 53 to 76%. And not only there was improvement in the 7 to 10 day blood pressure appointment, but there was also overall improvement in the rates of a 6-week follow-up. And obviously this is not 100%, but it's definitely a good start. And then the other thing that we noticed was because we standardized all protocols, so we didn't discover a new drug, we didn't like tell them to do any rocket science things, nothing. They were just treating blood pressures. And what we found was there was a significant reduction patients who were hypertensive in their first 24 hours postpartum, so while they're in the hospital, but there was a very significant reduction in the rates of severe hypertension prior to discharge. So we were obviously, following the protocol. And some of the things I did was I literally made posters out of these protocols and put them everywhere that have easy access to residents and all our learning people. And similarly, we found a reduction in blood pressures all throughout, all the way up until 6 weeks. So quickly, I think I agree with Dr. Hollier that, telemedicine is actually the way to go. So we, at the University of Chicago, at least, we are actually going to do telehealth program. It's a hospital-wide program, and they came and asked us what would be the one program that we want to propose from OB. And I said, let's just propose the self-management of blood pressures postpartum. So hopefully we're gonna, it's an institution-wide, so it's taking a little bit of time, but I think remote patient monitoring and telehealth will further improve the compliance and control of blood pressures. And one last thing, I definitely want to say that all of us who are doing research, we should be really largely very much aware of this, racial bias. And at least, I've been attending a lot of conferences, and I think just having whatever metrics of improvement you're trying to say that you improve, I think that should definitely be checked against race. So you should say, okay, did I actually make a difference in entire patient population? Yes, no. And did I actually make a difference in the patient population which is most kind of disadvantaged when it comes to management of hypertension? I'm going to stop there. Thank you so much, Dr. For giving me this opportunity to talk, and I can take questions now or later.
Thank you, Dr. Rana. We're going to ask all of our panelists to plan on taking questions at the end. We left some time at the end for question and answer. So we're going to move to our next panelist, Barbara O'Brien, and I am not going to read her whole bio because it is extensive, but she did begin her career as an RN in a tertiary hospital labor and delivery unit 34 years ago, hard to believe, and has 18 years experience as the director of the Office of Perinatal Quality Improvement within the Ohio University Health Sciences Center College of Medicine. She is an active member of the Association of Women's Health, Obstetric and Neonatal Nurses, or AWON, and serves as the National AWON representative for the Council on Patient Safety and Women's Healthcare, which is the group that develops the maternal safety bundles that we know as AIM. She is a member of the executive committee of the National Network of Perinatal Quality Collaboratives, and she serves on the Oklahoma Maternal Mortality Review Committee and the Fetal and Infant Mortality Review of Central Oklahoma's Advisory Council. Ms. O'Brien